Hey y'all, and welcome back to the latest episode of Code Brew. I'm Joe King, and I'm here with my co-host, Lukewarm.
Hey everybody. Was that fast enough this time?
Yeah.
They say I'm slow to respond.
Yes, they do.
Super.
Slow to respond. Like, whatever your friend, who's slow to respond?
What is the
Encephalopathic people.
term?
He's
Oh, okay. So what with that?
lactulose.
Is a hepatic?
Hepatic encephalopathy, yeah, slow to respond, like you're moving through jello. That's you.
I was just talking about a drink.
At baseline. Oh, you weren't just talking about a drink.
Singular.
Anyway, so we're back. It's episode 11, and we're talking about trauma ICU, trauma nursing, trauma ICU. We have a special guest with us. Jay Easy is here.
Hey everyone.
And we are, we're gonna get into this.
Jay Easy.
Jay Easy.
Wonder how we got that name.
Yeah, we're gonna go into it probably.
Oh.
Well, I bet he'll tell us. But
Oh yeah.
we do love it. Jay Easy. He has another name on the podcast. We have previously referred to him as J Dog. That's what I came up with on the fly, but he's Jay Easy.
For sure, both family names.
Definitely.
Absolutely.
Both
Yeah.
family names. So yeah, we're talking about trauma surgeons, we're talking about gnarly injuries, and we're talking about chaos. You know, trauma is a lot of times chaos, and it's going to be really exciting today. So before we get started any further, we're going to go through our disclaimer like we always do. The views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational and entertainment purposes only and should not be considered medical advice. So, first thing I want to just let Jay Easy introduce himself. Tell me about yourself, man.
So I have a background. I've been a nurse for about going on 15 years now. 10 years of my life existed in a trauma ICU. I did everything that worked from, well, I'll go back even a little farther. Prior to
In a major metropolitan area. Yeah.
And prior to that, I worked in that same hospital as a PCA on one of the step-down neuro floors. Graduated from nursing school and was lucky enough to get into the trauma world. They did. There's more to it. There's some gaps that I'll just leave out during that time. But I was brought into the trauma ICU, and I was really fortunate to get into the unit that I was in. After a while, we all kind of bonded together, but we noticed that we were...
Trauma bond.
Well, there's that. We were the land of misfit toys.
But it's a thing.
That's
100%. It 100% is, but we were all a land of misfit toys.
Oh, yeah.
We had people from every aspect of life.
Yeah.
And it was great. And I know a lot of them.
ERs kind of has
Yeah.
weird island of misfit toys kind of feel to it too. Yeah, I definitely, it's really cool. It creates a very interesting, fun family. I can definitely relate to that. But you're in leadership, you're ICU leadership, you're in hospital leadership too. So your career has really evolved.
Yeah, and it was very interesting. Like when I went into the ICU leadership role, I moved out of my comfort zone, which was trauma, and I went into a medical cardiac world. So that I switched my entire profession. And I had to learn from some phenomenal nurses when I got over here. And I had a lot to learn.
Yeah, because we don't do trauma where we currently are.
No.
And I mean, it is you're, even though you're going from ICU to ICU, going from a trauma ICU to a medical cardiac ICU, that is very different. That's a change.
I mean, even if you put me in NICU, I'm like, what? What is this? I mean, I've seen an EVG drain 1,000 times. Every semester, I see one. Someone explains it to me with students, and I'm like, yeah, I got it. And then the next semester, I'm like, what is this again? I mean, I just don't the draining process or whatever. I'm just not. You become so familiar with specific patients, specific.
In and out of fad too. EVDs kind of go in and out of fad sometimes, depending on the injuries and stuff. So you almost
well, some facilities use them a lot more.
That's
than others.
Yeah, no, for sure. But no, I mean, so you've you've changed gears a few times, and now you're like in leadership, which gives you a whole even different perspective. So it's pretty cool. So first things first to like talk about. I wanted you to talk like your first, like a memorable case from trauma in the beginning.
So that one was really hard because you had told me about this, and I had a very hard time trying to remember the first trauma case. I think some of it, and it will kind of roll into some other things we'll talk about, but I have a background in the military.
Oh, that's right. I forgot about the military background, bro.
So
no trauma there.
No trauma.
Different kind of trauma there.
But I was really thinking about this, and a lot of people go, I remember the first person that passed away, and I do.
Oh, yeah. Oh, absolutely. We all remember our first code, yeah.
But the one that has always stuck with me the most was we had gotten a new grad from another unit pulled to my unit. Mm-hmm. Their charge had called and said, basically, take care of them. I thought I set them up for success, and they were doing just fine, but then one of their patients decompensated quickly. Mm-hmm. But even working with that nurse, because we all came into that room to help her,
right.
She got to watch the progression of a complete respiratory failure.
Yeah.
And like the steps you're going to take. And it was very methodical, and it was almost textbook.
Like, it sounded like she had a good team.
I thought at first the team that she had there, like her patient team was good, but the nurses I had on that unit.
I think we're saying good nurse team.
Oh, yeah.
Yeah. A good team to learn from.
Yeah. Oh, yeah.
Patient-wise, a good team to work with.
Yeah. I came from a phenomenal teamwork environment.
That's one of the things about trauma that I feel like that's one of the hallmark things about trauma is you're like truly trained.
All hands on deck.
Jump. It's like you're going to you go through your trauma classes like your TNCC and stuff. Like it really specifically. I mean, it's kind of like ACLS where you're talking about it always is about the team, but from trauma, it's always about team as well. From the initial assessment of the patient all the way through. So like your full patient management from a trauma perspective is about the team.
Oh, absolutely. Yeah, I would agree 100%.
Yeah. So she got to see the full like respiratory arrest, kind of like to see the patient decomp and all the steps.
Yeah, and she did a phenomenal job through the whole thing. Even after she got done, I know she was visibly upset. Mm-hmm. And I felt like I failed her because I was like, this was not my intended purpose for you. I wanted to take care of you, and I feel like I did not do my job.
Yeah.
But she's
probably not true, but I understand the sentiment for sure.
But she did so well, and it was like, I'm telling you right now, you did not lock up, you did not freeze. You did everything like perfectly. I could not ask for anything better.
Which is the kind of feedback that you
nice to affirm her. Yeah, nice to affirm her, and then,
is important.
That also goes to you feeling like you don't do your job as like that goes to like the stress that we take on in our careers of like how we're constantly thinking back, like, was there something different that I could have done? So like when I'm at home processing stuff and my husband doesn't understand that I need alone or quiet time, those are the things that I'm processing.
Right. No.
That people that don't work in healthcare can't really understand. It was like, what about if this, like just the zillion different scenarios that you can run through your mind.
From a day to day, like I'm always wondering, like, could I have done something better? And then you have someone who deteriorates in it. And then a lot of what we do now is we're only involved when somebody's deteriorating. So you're like wondering, like, could I have been involved sooner? Or did I do anything that could have made this worse? Or could I have done something that made this better? I mean, we were always like completely unpacking every piece of this. So
that's the learning.
It is learning.
Reflection.
It is. Reflection is learning. But like, for you as a leader to be able to take her aside and be like, listen, you did everything right. Like that is like, that's feedback that you can give somebody that's going to help them grow and also build that confidence. And a lot of times, like that is the kind of confidence that sets you up for success for years to come. Right. I mean, just a recognition that that's like super positive for people.
Yeah.
And like as leaders, we need to be doing that for our staff, like making sure that we build them up. Like there are going to be things that come through and drag you down. Like, it's a given. Like, that's the business we're in, is bad news, right? I mean, honestly, healthcare. So, like, whenever you have, like, someone from leadership takes you aside and gives you that build-up moment, like, that is key. That is super key. But, so let's get into the meat of the trauma ICU. So, like, what makes it different from the other ICU settings?
So I actually reached out to some people I used to work with.
Cool.
And I was trying to put it into words because it's very difficult for me. And I actually, one of my old charge nurses, I think she said it best. It was, the events are so acute. Right. It's not a chronic issue that's happening with them, right?
I mean, you couldn't see it coming.
Correct.
Yeah.
And typically, the way I visualize this, if I have a chronic issue, I know in the back of my head I could end up in the hospital.
Oh, very true. Like diabetes or high blood pressure or, CHF or something like that. You always know, like, this could get worse.
Right.
This is 15-year-old.
Right.
Four-wheeling? Is that what it's called?
Yeah. Oh my gosh, yeah.
Four-wheel driving. Four-wheeling. Four-wheeling, flipped over.
Right.
No past medical history, but super unstable or related to hypovolemic shock, broken, whatever. So it is very acute and probably unknown of what was going to happen.
The interstate, and I'm going 65, and I'm obeying the law, and, like, somebody just comes and hits me head on going the wrong way, and, like, my day was normal until it's not.
Yep, it's a 15-second event. That
right.
YouTube,
so
not a 15-year.
Actually makes me think, which let's get into the trauma, but how difficult it must be for the family too.
So that,
because with chronic, I'm like, well, they're 80. We told them not to smoke for 25 years and, do this and do that. And
you're 80. I hope we've been telling you a lot longer.
Well, I mean, but,
years,
yes. Well, whatever. I mean, like, so you understand that decline, that progression,
right.
quote unquote,
event.
Whereas this is much harder to grasp. So another tuned skill that you need to.
So I've actually been a family member of a trauma patient.
Really?
Right. So, and I haven't actually talked about this on the podcast. This was kind of part of what led me to nursing. I guess part of my story, but, like, my brother was in a very serious accident. He suffered a head trauma. He was 14 or 15, freshman in high school, fell out of the back of a truck on the road and cracked his skull. It's obviously a very traumatic event for my family, right? My parents, it's weird how, like, word of mouth travels, right? In a small town. I'm from a small town. And you get this phone call and people are like, Adam's laying in the middle of the street, or like, a lot of weird stuff. I mean, it's hard. I mean, of course, this has been...
Like, they're there while he's...
Right, so we got, like, a phone call from someone who, like, saw at least part of it, like, saw him laying in the street. And, I mean, like, you don't get all the information at one time. So you're like, is he dead? Like, is he... I mean, it's a very strange... evolution, like, where time seems to move very slowly and very fast at the same time.
Mm-hmm.
And you're, like, trying to get all this information, and I'm trying to talk to my parents, and so EMS was called, put him in the back of an ambulance as, like, a typical... I mean, my brother's not a small person, so, like, he's having your typical head injury. He's combative, like, your battle sign, your raccoon sign, he's got the whole thing, right? So, I mean, he has, like, an occipital skull fracture, a blown eardrum. So he's got all these different things, like your classic signs of a head injury. And he's a pretty decently sized, like, offensive lineman from freshman in high school, and he's, like, tearing up the back of an ambulance. So he was originally going to the children's hospital, where they have a pediatric ER, and they had to make a quick detour at the little country hospital right there in town, which is, like, we're automatically thinking the worst, right? Oh my God. But it's really just because, like, he was tearing up the back of an ambulance and they needed to, get him a little more stable before they took him down to the trauma center. So he did eventually go to the trauma center. He spent some time in the pediatric ICU, and he got discharged after a couple of days. And I mean, he's made a full recovery, but I do know what it's like to be a trauma family member. Like, I understand what you're saying, because in those moments, like when you get to the hospital and you're like, I need all this information. I mean, I was a kid, right? I was 16, 17 years old, probably 16. I mean, we're pretty close in age. So I didn't understand any of what was going on. Now, looking back as an adult, I know a lot about what was going on. But in that moment, you're just like, I'm trying to
process.
Yeah. And you're trying to process everything. And your medical staff, because they know what they're doing, they do this all the time. Like, they're helping you process in a way that you don't even realize is happening, but you're relying on them.
Oh, yeah.
Because every little piece of information is really important.
Yeah. And the KISS method works really well.
The KISS method?
Keep it simple, stupid.
Oh,
oh my gosh. I like this. I have heard that. Is that a mnemonic?
It could be. It's just something I've heard. But it was something, to your point, to help family process things. It was, let me get this to the simplest version.
Right.
I understand what's going to happen in the background, but I want you to understand what's happening currently.
Yeah, like even my parents are non-medical. My dad's like a forester by trade, and like my mom, which she did work in healthcare at an OBGYN's office, so like it's not the same.
No, that's a totally different.
Not even close. So we didn't understand what was going on. So we were really relying on the staff of the hospital, who did an amazing job. I mean, he got the best care. But no, I do understand what it means to really not know how. And I mean, like, and then you're in high school, so there's like this whole other piece. Like, he has all these friends and all this community support, which is amazing, by the way. Community support. Being from a small town, like, we had a lot of community support in our church and everything. But like, you're trying to like get that information out to other people too, so they can disseminate information to cut down on the number of calls that you're getting. And this was like, pre-Facebook. Oh my gosh, pre-Facebook. I don't imagine.
We had to find people on Facebook.
Yeah.
Oh yeah, that is a thing.
I did that this week. Yeah. I was trying to find a family for a patient here in the hospital before she passed away. It was I should get into that at some point about what happened with that. I guess I could say it real quick. So it actually like had like this patient was wearing like a piece of jewelry, and it had someone's name inscribed in it, and like using a lot of resources online, like classmates.com, like social media of all types. I was able to narrow down the person who originally owned the piece of jewelry, and how they had somehow like been trying to help the patient at one point. The patient had somehow come into possession of it. And I was able to find the identity of the person, the patient who was in the hospital, through going down that whole rabbit hole. So, and I mean, and her family was able to get here before she passed away, which is the whole goal. And yeah, it was wild. I hate the idea of someone dying alone. And so like whenever that's happening, I can't really focus on anything else.
Oh, huge proponent of that one. No one dies alone.
No one dies alone. I mean, even if it's like our staff who's there at the bedside, I love that. Like I'll our staff, and nurses are wonderful about being there for patients, but at the same time, like if we can do what we can to get their loved ones at the bedside, like we're going to do that. Even if that means like we let their dog come in, even if that means like, I mean, I support it all, right? You know, like, because animals grieve too, just a side note. But anyway, sorry, we got off on a tangent. Let's talk about trauma ICU.
Have we talked about trauma ICU yet? Okay.
Yeah.
We're kind of going all over.
But this is great, No, I do. I want to talk about trauma ICU and like the different things that you encounter there. I mean, like, especially the different types of injuries. I think that's one of the things that makes it like so. Oh God, it's so fun. Honestly, I mean, I'm going to call it that. It's fun. I feel like it's fun. I loved working trauma. I did trauma as well for a long time. I did not do trauma ICU. I did trauma from the ED standpoint. That was a level 1 trauma center. So, let's talk about all these different types of trauma patients and the things that you're going to encounter.
All right, so you can have motor vehicle accidents, and that even includes motorcycles.
Oh, yeah. There's a
I
lot.
saw a lot of those.
Oh, yeah.
You get your gunshot wounds.
What do we call them? Murder cycles?
Well, there's a few other nicknames that are appropriate.
Yeah, it's totally inappropriate. But yeah, no, please don't ride a motorcycle. They scare me to death.
You get your gunshot wounds, and even going through, like my background with the military, I know which caliber bullet is worse than the other one, and I have a good idea of what you got hit with.
There's a whole science behind that.
There is. You get stab wounds. Luckily, I didn't have a large amount of those, like from a knife or anything, but maybe
a lot of your stab wounds, I feel like, don't end up in the ICU. I mean, like they have to be pretty like targeted, like perfectly targeted to end up in like critical condition. I think for the most part.
Yeah.
I mean, gosh, I feel like bowel perf, like you're not.
Oh, I mean,
like what are you concerned? I mean, I don't know. I don't have stab wounds, but I feel like
force needed to like get.
Are we just talking about like one stab or?
Well,
like I fell on a kitchen knife.
Most people don't carry a large enough knife on them either.
Right. I mean, you're talking about a pocket knife is like a couple inches long, 3 inches long, 4 maybe. And like to get down to bowel level, I mean, you got to put some force behind it, man.
Yeah. And the human body, obviously, it felt it, so it's pulling away.
Right.
So
they usually don't get deep enough. I mean, unless you're talking about...
Yeah.
People aren't walking around like Mick Dundee.
Yeah, no, they don't.
Mick Dundee? Crocodile
Dundee.
Oh, Mick Dundee? Like McDonald's?
I don't know.
That sounds cool.
That was different.
It sounded cool.
No,
I think I agree. I mean, now if they go for the neck, like some of those, like a neck stab wound.
I have seen those.
Right. I mean, yeah, those can be critical. No, for sure.
There's even falls, young people and old people. So you get a lot of
people.
So like what fall off a ladder, like
so there's
fall off a roof, like is that what we're talking about with trauma?
Yeah, so I'll give you an instance for like a young one. There was a Amish family. They had a kind of a I don't even know what the word is. They had a cliff essentially, and one of the things all the kids would do is go hang off this tree limb and swing into this cliff wall. Well, he slipped, missed the cliff wall, and fell 50 feet.
Gee,
oh,
that's
right.
No way.
So that's like
five stories.
Yeah.
Roughly, yeah.
Yeah.
And then the elderly ones, those are typically like, hey, they're gone up to the attic, they're trying to get something, or they fell down the stairs because they were going downstairs to get something.
Yeah.
Those are usually the elderly ones. It's like putting up Christmas decorations.
Yeah.
The holidays is the worst season.
It is a lot. Or, I mean, you can have some that are just like a slip and fall, like outside. I mean, whenever it's cold outside, we've definitely experienced like the ice and stuff here recently. So, I mean, your elderly people, they don't have great balance anyway. And then you add ice to the mix and it's bad.
So what's like priority assessment, like stabilization that you're going for with those patients?
So, I mean, as far as your assessment goes, like there's, I mean, literally a whole class that talks about trauma assessment, but like you really go injury specific, but you do like a full trauma survey, like head to toe. Like you look at the injury and like stabilize as far as your ABCs go, and then you do a full trauma survey, which starts at the top of the head and goes all the way down to the tip of the toes.
Yep.
And you strip them naked. And my son knows about this because he flipped his Power Wheels Jeep in the yard one day, and I did a full trauma survey in the yard. Stripped him naked. And he was like, my clothes. And I was like, hush, I've got to look at you.
But he can talk.
He's
breathing.
Yeah. Well,
let's do a GSW that comes into the ER.
Yeah. Tell me. I want to hear.
So from the ER perspective, where I work, they went into what we called room 9. And everything came off. Everything. They looked for the entrance wound, exit wound. If they couldn't find it,
just take it off. We cut it off.
It's cut. There is no saving. We're not ginger about this.
Yeah.
They will
cut everything from turnouts to prom dresses to God only knows, all sorts of stuff.
Oh, and the ER goes on lockdown.
No.
It depends on where you were.
Oh, not every time.
The place where I worked level 1 trauma, the places, like, there was one place that did, there was one place that if you did that, they would be on lockdown constantly. So what's the point?
So I know they go into that bay, they get their clothes cut off. There is a room full of people in there.
100%.
From radiology, physician, 2 nurses minimum. You got your techs in there that are you're barking out orders trying to get things, they're going to get it for you.
They even have designated places to stand.
Correct. RT is in the room if needed. And they start there, and it can grow from there. But you have a portable, at least theirs did, had a portable in there. They would take chest x-rays. They would take pictures of everything they could.
Oh, yeah.
They had a checklist, very like the room 1 does where we currently work, where it's paper orders and it's check boxes.
Yep.
Right?
And then once you get them stabilized and you looked at everything, you've drawn your labs, you made sure your airway was patent, then, I mean, really your first priority is to get that advanced imaging. Like, how quickly can we roll them to CT and figure out where that bullet is and what it's hit on the inside.
And one of the ways they know if they can turn you or not is, so they're going to look for spinal cord injury, right? So they're going to turn you and they're going to check for rectal.
Everybody is getting turned. Everybody.
Check for what?
Rectal tone.
Rectal tone.
Oh, and that'll tell me. Oh.
Yeah, I mean, pretty much everybody in trauma, whenever we say a full trauma survey, I'm telling you, we check every single thing and everybody gets a rectal tone, to check for...
it's just a reflex.
Yeah, it is. And I mean, it's like, oops, surprise, finger in your butt. There's a guy I worked with, I won't say his name, but it was an ER resident. I swear to God, he had the biggest fingers I've ever seen. And every time he was on to do like the rectal check, I was like, oh God, this is going to suck for you. But here we go.
Oh my God.
I mean, sausage fingers to the max.
Oh. Oh.
Yeah. So, but like in that instance, everything in it is organized chaos.
Completely organized, but also chaos.
Think of just like your Code Blues, it's organized chaos. It's clear communication. You have your nurses that are establishing the access point. You have a doctor that's assessing the patient.
Multiple doctors.
Yeah. You have your charge nurse that is kind of standing at the backside saying, heard, we're ordering this. Can you draw? Bump, 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 bump.
And like care coordination.
Yeah.
They are coordinating the whole thing.
Well, like you have different, like your ED staff, like that doctor is usually on the airway and like holding C-spine, like that's some of their primary, but like your trauma staff, like your trauma surgeons, like they're looking at everything. They may be, like if you've got chest injury and stuff, they may be preparing to do a chest tube right there. We do it quickly. I mean, if you're, God forbid, your patient's coding with a penetrating trauma, they may be preparing to crack that chest open. We do those kind of things. So, like different, a lot of different priorities for the different pieces of the team. Right.
Yeah, I know, like, when I have students that go to the ED and shadow, like, they'll come to post-conference and, like, every single thing that they say seems insane. Like, they're like, well, yeah, I mean, wasn't that busy? We just sliced open someone's abdomen and pulled out their heart. And I'm like, what are you expecting to see on a daily basis? This is insane.
Should we tell them that
I don't know what you're doing.
Or is not in the abdomen?
Well, we could, but
okay.
Whatever. But they're just listing just all this stuff. I mean, it's just it's all insane. And I'm like, you saw this in just like a one shift.
Oh yeah.
So when it's crazy, it's really crazy.
Yeah. No, I remember the first time like I saw my first chest crack, and I actually like saw a patient's heart beating in their chest, and then I saw like the trauma surgeon do like cardiac massage. I mean, I've seen some stuff, right? But I mean, like you see these things, and you're like, oh, that's the heart, and it's actually beating inside their chest, like it's.
But it's beating.
Cool. It was beating. I mean, at that point, it was beating. But yeah. So many things, like there's so many different types of people can hurt themselves in so many different ways. I mean, I'm from a rural area, so like
people are bored.
Well, yeah, that, but there's a lot of farm injuries. I mean, I can tell you.
They're gonna say firework.
No, well,
those do happen.
They're seasonal. We know when those are occurring. But no, like farmers like run over themselves with their tractors a lot. I don't really understand how it happens, but it does happen.
They need those jet ski keys,
like the ones like that pull.
Like where
they do have like the pressured
pops off.
It's supposed to help, but I think like if you're going and like you just kind of slip underneath there, like it takes a second to stop. I don't know, man. I'm just telling you, people roll over themselves with tractors a lot.
Yeah, on another farming one is the PTO shafts that hook up to the equipment that they're attaching to. Those things are open, free spinning.
Oh, and they'll suck up.
And they will
finger
snap you right into it.
Yeah, they will.
That's why you see farmers wearing like overalls, because they're trying to keep their clothes in so it doesn't fly everywhere and get caught into them.
Yeah. I mean,
So it's
really
not
true.
it's not a fashion statement.
No, well,
I thought it was like cold weather or
Well, no,
you see like the Carhartt overalls.
oh yeah, but you could store stuff too, right?
And so I don't get sucked into something. Oh,
Possibly, yeah. Workplace stuff, like people all the time. I mean, I had a guy like cut his whole freaking arm off at the shoulder with like the blade of a cement truck. I don't know how it happened, but they brought his arm in like the dirtiest cooler that I've ever seen. I was like, did y'all find this? Like, did you literally pull this? Like,
we looked for the dirtiest
they
one that we could find.
dirtiest cooler through that arm, and it brought it in. I was like, well, I'm just glad it's here. We can't.
That's what I was gonna say. Are you happy that it's there? Or?
What about hold my beer injuries? Do you have any good ones?
They all involve a four-wheeler. Every single one of them.
Oh, fireworks!
You're targeting us country people.
No, I'm laughing because that is seriously a lot of the hold my beer moments. It's like they got on the four-wheeler and they just did this and ran into the barbed wire fence. You're like, the fence didn't appear overnight.
We'll have to unpack my barbed wire scar at some point, but I do have one. And I was too young to drink at the time.
Hold my beer.
Yeah, I was too young to drink.
She's the story.
Yeah, I am from the country, right? I mean, I have not personally driven truck on a four-wheeler, because my dad is like, I mean, he's seen some things too, being from the country, but like, yeah, no, I mean, you're right. I mean, there's a lot of four-wheeler stuff. Us country people are crazy. So anyway, so the ICU workflow, I mean, this is something I kind of want to like, my stuff is from the ED. So like, talk to me about the workflow and kind of what your like typical, what you would see. Cause I don't know, like, I don't know what it looks like from an ICU standpoint.
So you guys are kind of hearing like the ED, it's down and dirty nursing is what I call it for trauma.
Oh yeah.
When you get into the ICU, this is where you really have to have an amazing set of assessment skills. And that is what we push on our orientees when we were getting, it's like, you will assess head to toe. You will know every mole on their body.
Rectal toe.
Yeah.
We've had to do it.
Oh yeah. Oh yeah.
You will know if this bruise was this size, you're going to trace it because I want to see if it grows. You're going to look for any positive signs of any internal bleeding, swelling of the belly, so on and so forth. If they have a pelvic fracture, what is the number one thing you're going to watch for? For them to bleed out into it.
Yeah. Into their Foley, yeah.
Well, it's not even in their Foley.
Oh, well, into their pelvis. Yeah. No, perfect.
And there's no like positive sign other than a hemodynamic monitoring.
Yeah.
So if you're not,
or you feel like some of that dependent lividity like sinking down, like when you turn on and you see that like blood pooling in the buttocks. A lot of times are like in the like perianal areas. No, for sure, I agree. And we keep hammering home like the importance of assessment for our listeners, but dang, like I mean, it's so freaking important. Are y'all listening? It's important. Assess your patients.
And that's the key to being any nurse. It really, really is.
Absolutely.
But yeah, I mean, you're going over everything on them with a fine-tooth comb, and you're understanding everything that is happening. And trauma is once you know the mechanism of injury, or where the injuries are, I should say, it is pretty much a standard protocol of what will happen, things to watch out for, and you can start mapping out your night with that patient.
There's a lot of structure to trauma. Like once you've identified the injury, I think the American College of Surgeons has kind of like made that a priority. I mean, you see, when you look at accreditation and stuff, like we all basically have to do everything the same way for that purpose. So whenever you're getting that level 1 trauma or what have you distinction, you're basically being told like you're going to do things this way or we're not going to accredit you. So
correct, because this worked for X amount of patients.
Right. I mean, it's all evidence-based and it's all, which really helps that standardization. Like it gives us the tools that we need to know exactly what to do for each patient. So, and I think it's valuable.
Oh, yeah. Well, and also when it comes to trauma, you have more than just like, hey, the mechanism of injury was a GSW or motor vehicle accident. I can guarantee you if you're in a motor vehicle accident, you're going to have a head trauma.
A lot of it, yeah.
So then what's going to come with that? What can you expect? What medications to come with it? You're going to go do a scan. You're going to be doing at least Q1 neuros for the first 24 hours.
Oh, yeah, we scan these people from, do a pan scan. From the head, like top of the head to like the mid-thigh at least, sometimes lower. Yeah.
Yeah, we would do the whole gambit. And you were really pushing. When I say pushing, you're pushing the patient to make sure that neurologically they're going to stay intact, but then hemodynamically, whatever else you got to do. Trauma is a big hemodynamic game.
Oh, very much so. Right.
Well, and some of it, like, can't that initial bleed, like, have enough pressure on it in the beginning to where it, like, controls the bleed? And then as that pressure starts to relieve later, you have, like, massive hemorrhage?
Depends on the type.
Like retroperitoneal bleed or...
Oh, yeah, it depends.
Any of those. I mean, like, those are the ones that...
Yeah, and that's why
I've seen.
You can almost anticipate every trauma patient, they're going to OR, and they're going to get an exploratory laparotomy.
Yeah, look.
We're going to go and find it.
Oh, yeah.
We're going to go searching.
Oh, yeah.
Because I don't want to say
we're going to go searching.
We're going to go searching.
Yeah, that's really what they do. They open them up. What do we talk about? They open them up from the pubic bone all the way up to...
Xiphoid.
The xiphoid, yeah. And, I mean, they wide open and let's look around.
And they run... Meaning they take their hands and they run your entire mouth.
Oh, yeah, they do that.
Oh.
Yeah, to make sure there's no injury. Because that's the kind of thing that will creep up on you later, right? I mean, there's a lot of nuances with different types of injuries. I mean, things that it's hard to even... I would love to, like, talk about trauma again. We may have to have you back on and talk about trauma again because there's really so many things. But I like crush injuries. Like, that's a whole other thing. Like, how you handle crush injuries and how you blunt trauma versus penetrating trauma. I mean, there's like so many different things to look at. Just the orthopedic injuries from like, the different types of fractures are so they're all handled differently.
Correct.
But at the same time, all of the same type are handled the same. There's that standardization.
Correct.
Yeah. So, but yeah, and one of the things like, I did want to touch on something we don't talk about very often is like the triage that's needed when it comes to like the trauma stuff. Like we triage a lot. Like we talk about prioritization, which is a lot like kind of the same thing as triage. But whenever you're like dealing with trauma patients, you're trying to like look at sick versus not sick. Like sometimes you have multiple coming in. Like if you have a car accident, it's 4 kids. like 4 teenagers in a car, which unfortunately happens more than we would care to say, but like, you're trying to say like, okay, this one can wait a little bit, this one doesn't, this one can't wait, this one, so like there's a whole lot of that too. So let's talk about like trauma resuscitation and from the ICU standpoint, like the different things that you're going to be using. We talk about hemodynamics, but
I think one of the biggest things to look at is the administration of blood products.
There's a lot.
That it is. So we always went with the adage, I like quality over quantity.
Oh, yeah.
And for every best practice now is what we're seeing is that you should be giving whole blood in these situations. So mass transfusion.
Yeah.
That's when we should be giving whole blood products to these individuals. We're finding through evidence-based practice that this is what is shown to have a better outcome for the patient.
Get away from like crystalloid and load them up with that kind of stuff.
Correct. Because you set them up with crystalloid, what will happen is our vessels are going to dilate. You're going to third space everything that's going in. So you're doing something for nothing.
Right.
So if you do the quality, like your albumins, your FFP, so when we started, for every red that you give a yellow.
Yeah, we've got to give clotting factors.
Oh yeah,
correct. Yeah,
and that's another huge thing that goes into trauma too.
So yeah, you've got to give them something to clot off.
Right, and that's a huge thing too. So like the Eliquis or the Plavix, the stuff that we can reverse, but it's really hard to reverse or control it. Like that's another level into it that you really.
When you're trying to manage those comorbidities too.
Yeah.
Yeah.
On the older individuals that have it.
Right.
Does it happen all the time? No, because typically your trauma people are, younger people that are able to go out, ride a motorcycle or,
right.
do these activities that are
cliff,
Yeah.
whatever. Yeah, no. It is much more complicated whenever it's like an elderly person. I mean, you expect the head traumas in the elderly from falls and like the hip fractures and things, but like whenever you get someone who's like an MVC or like, I mean, God forbid, like somebody got shot and they're like 80 years old or something, you're like, what? First of all, what were you doing? Second of all, oh my gosh, I got so many comorbidities to deal with. It's wild.
Yeah.
I mean, I think it's, there's a whole art form to like handling the comorbidities and trauma patients, because that definitely is such a huge complicating factor.
Yeah, and I think even when you're doing like those MTPs, we love to track what we gave. I've given 4 PACT, I've given this. And when the doc comes in, I'm able to say I've given 2 liters of crystal, I've given 4 FFP, I've given
exactly
right.
Given.
So then he knows, and it's visual to he or she knows. It's visual to him, and it's like, okay, we should have stabilized by now. I think we're gonna have to go down for a scan. They're bleeding somewhere. I gotta find it.
They need to go back to the OR or something. Yeah.
And
I mean, we would like to be able to get somebody to the point where we can actually get a peek at it through imaging. But sometimes, like, if they're too unstable, it's like, we just got to go back.
Yeah, we're just going to have to go back.
Yeah. I mean, a lot of times, like, your patients, from in the trauma ICU, a lot of times they're coming right out of the OR. Like, we don't, take them from the ED to the ICU. We take them from the ED to the OR, and then they go to the ICU, so.
Yeah, and we were actually part of a pilot program where I worked. One of the nurses from the unit I was working on did a trauma resource nurse. And their sole purpose was a level 1 trauma came in. They were attached to that patient from the ED when they arrived to the OR, and they were helping family as well.
Yeah, I've seen that.
And then they would come up to the unit and be like, hey, this is what you're getting, because we all know we get a report from the OR like, hey, they lost this much blood, and we did this. And you're like, okay, what else?
Well, yeah, no, I've seen the trauma resource nurse, and I've seen like how well that can help. I mean, from managing the family, but also like being so that there's like less multiple handoffs, because whenever you're changing hands, I mean, that's for whenever some mistakes can happen and stuff. So yeah, no, I think that's a huge. I think they can be a valuable resource.
Oh yeah, they were phenomenal.
I've worked at a few places that had like like trauma nurses. I mean, at one place they called them red surge, another place they just called them like the trauma team. It was really helpful. And I like that. I think the ACS has really gone towards something like that too, where they're wanting those trauma resource nurses as well for like advanced training and stuff. So I think they've.
I would agree with that. They filled in a lot of gaps that I would have to.
Very much. I mean, like, as for your core staff, I know from the ED standpoint, like having someone who like was maybe focused on the documentation, because a lot of times like that for a trauma, like there's so much extra documentation. Like somebody who's like just checking over all of those things by itself is very valuable. So, one of the things that I like to talk about as far as trauma goes is like, and we talked about the team approach, but it's really important, for a team approach, to, the different parts of the hospital working together. I mean, I think that trauma team is part of that, but how important is it from a trauma ICU standpoint of like working together very closely with like both the OR and the ED?
So I think those were really good relationships that we had. We had an understanding.
Yeah.
And it was, I need you to stabilize. I need them up with me.
Right.
And that was from the ED and OR's perspective.
Right.
Let me take on more brunt of the work. I think the biggest one that I had that I would stress for any new grad is you become best friends with your respiratory therapist.
Oh, yeah.
Like,
I've had some great RTs along the way. No, for sure.
That's good that you're saying that this episode.
Oh my God.
I recognize that tone.
It was. She shouted out to the pharmacist once during COVID, and I was like, RT.
Yeah.
RT.
I did talk about RT, but no, you're right. I mean, RT is really valuable. I've been very
so much to teach, so
Yeah,
much to learn.
so much
Yeah.
to teach. I've been very, very lucky that I've had some great RTs along the way that have kind of shepherded me. There was like one in the very beginning, and he's deceased now, and I miss his friendship and also his guidance. But gosh, like he was so freaking smart, you know. His name was Scooter. He was awesome. But
Okay, I'm digging them. Is that his real name or nickname?
his real name was not Scooter, but no, he went by Scooter, and I mean, loved his job, and had a lot to teach, and was always willing to, and I was always willing to be helpful. But yeah, no, I mean, I've been very fortunate. I think RT, I have to agree that you really need to buddy up with RT. I always buddy up with RT, but
Well, I mean that from the. I had some, like you, I was very fortunate. I had some very experienced RTs. And the thing that I think any nurse should do is always try to build your knowledge base.
oh yeah,
And it's even, okay, well, if I did this, what do you think would happen? And just going through it, it's like, hey, what are you looking at on this?
right.
I'm not understanding.
Like, don't be, somebody who can like walk you through the vent and help you understand what the goal is, and like not to be intimidated by that machine. Yeah.
Right, and kind of what they're looking at. And it's like, okay, so if this is, what should it look like on here?
Yeah.
No.
I had one that literally is like, it should look like a canary, like a duckbill should be right here as well. This is how it should look in the perfect world.
Yeah, brilliant.
And like was walking me through it, the KISS method, because that's what I would always tell them.
Right.
You have to KISS method because I'm trying to remember this.
Simple. Oh yeah. Keep it
Keep it
simple.
simple. Yeah.
And I've got to try to explain it to someone else later.
Oh, I mean, I agree. I when as a new grad, and like even before, like I was working as an ED tech before I got out of nursing school, and like I was very intimidated by the vent, or like anybody who was intubated. I mean, even though it was happening all the time, we were tubing patients all the time, and it was like, you felt like so much could go wrong. And then like I had that great RT Scooter who was like helped me understand, and and then I had some other people along the way who also I ended up working in critical care transport, ground transport and stuff, where I was managing a vent myself, and it kept me even more comfortable, because at that point you're like, oh well,
I got you. No worries.
here I got to figure this out.
What would Scooter do?
Yeah, no, for sure. But yeah, I mean, you can't be intimidated by them, because like you can manage a lot of patient conditions, like from blood pressure to, I mean, obviously respiratory issues. There's a lot of things you can do for your patient by manipulating that vent. I mean, definitely don't touch it without your RT, but
Or build that trust with them.
build that trust is great, for sure. So we have gone over so many cool things, and I think we need to make this a 2-part episode, like a 2-part series. Like I've really enjoyed.
Two-parter.
Yeah. I mean, we've done that before.
Trauma, the 2-parter.
Where we we've gone over a lot of things, and we went over our time because we just got like really deep into it and really enjoyed it. So, I'm suggesting that. Can I get a second? Y'all want to do a 2-parter?
I would like to make a motion.
Make a motion.
Yeah, I'll second that. I enjoy it.
Let's make it a 2-parter. So let me just go over the last few things, like so you had a tip for new grads that you wanted to talk about. So we'll have another tip for new grads for the second part of yours. So what's your tip for new grads for today?
So while you're in orientation, always ask for feedback after you do something. Be like, okay, what did I do well?
Mm-hmm.
What didn't I do well? Because what that will do is make even the preceptor a little more comfortable giving you that feedback.
Mm-hmm.
I learned that
Yeah,
by
that's
happenstance.
Yeah, because sometimes they don't want to say the negative.
Right. They don't want to give the negative. But if you're like, okay, what did I do good? What could I have done better?
It's my opportunity.
Yeah, and they feel more comfortable. And then after every situation that you're in, you should really self-reflect. Be like, okay, doing the same process. I did this really well, but I think I could have done this better.
In a healthy way.
Yeah. How can I do it though?
Yeah.
And it's, okay, I've noticed this occurred.
Right.
If I see that again, I know I'm going to do X, Y, Z now.
For sure. I mean, and I think it's good to unpack those things with someone else that's like, more experienced to like, you get that feedback, and then also like, this is what I saw, should I always do this? And like, use your resources,
Yeah.
But also, like, if you're gonna, do that self-reflection, just make sure it is in a healthy way, because we can do that in we can get to perseverating on things and let it become toxic. So, I'm preaching to the choir. I am someone who I can be toxic about, unpacking things later on. But yeah, no, I totally agree. Giving that feedback, I think, is super valuable.
It's super.
I mean, we should always, like, that's not really a tip just for new grads. That's just a tip, period, for everyone. Whenever you go through situations that you maybe weren't as familiar with, or like even something that's just like hard to process, like you really need to take a moment to reflect. So
yeah,
I love it. And be open to feedback, like something that we've talked about,
what's to help you grow,
right? It is help you grow.
It's not like no one really, I mean, not no one, but the majority of the people giving you feedback don't want conflict. Like it really is growth.
Right.
The goal is growth and self-reflection.
No, for sure. We work in a business where, people's lives hang in the balance. Like whenever somebody's giving you feedback, they do generally, you have to assume positive intent, right?
So, you do.
You have to assume positive intent. I mean, the way we handle things, I know I can be harsh sometimes whenever I'm in a heated situation or like a chaotic situation or whatnot. But just know that, like, positive intent, like, we're trying to do what's best for our patients, and I do want to see people do well. I do want to see my staff grow and that kind of thing. So I know y'all are the same.
Well, I hear you do a great job debriefing.
Well,
I've heard that just this week.
Oh my goodness. Anyway, so final thoughts. Anything you want to leave with us before we break this off and come back for an episode 2?
Oh no, let's hit part 2, because
there's so many things. I think I have more fun stories to tell. I haven't told it. I'm gonna work this story in. I had a patient who was under arrest and smothered someone to death, and I'm just gonna leave that there.
Cliffhanger.
But she smothered someone with her body. Okay, and like she was under arrest whenever she was my patient. I'll unpack that later, but it's a really cool story, and I can't wait to share it on the next episode.
Okay.
It's super fun.
I have so many questions.
I know, right? So we're gonna do our merch plug. We would love to see people out and about wearing our Code Brew merch, showing it to your friends. I have seen an uptake in our coffee mug. Oh no, I'm sorry, not the coffee mugs, like the travel mugs with the handle. They're like a 40 ounce and a 25 ounce. I'm hearing they're pretty cool. A few people have definitely picked them up. They're like a Stanley, but not a Stanley, but they have Code Brew on them, and I'm hearing that they are great. People are like drinking coffee out of them, but also water. I've just seen an uptake in people buying those. So that's really fun. But yeah, can't wait to come back for episode 2 with Jay Easy. Stay caffeinated, stay curious, and we'll see you next time on Code Brew.
Everybody,
thank y'all.